A warm welcome to everyone. The topic for the discussion is methods of gaining space during orthodontic treatment. During orthodontic treatment, space is required to move teeth into ideal locations. Then correction of crowding, retraction of procurement teeth, intrusion, leveling of curve of spee, derotation of anterior teeth, and also for correction of unstable molar relation. Following are the various methods of gaining space. They are proximal stripping, expansion, extraction, distalization, uprighting of molars, derotation of posterior teeth, and proclination of anteriors. Here comes the confusion and the great question. When to employ non-extraction methods? These are the answers. In case of mild to moderate space requirement, in case of constricted arches, when no skeletal component of malocclusion is seen, and also when no need to alter the facial profile. And the other names for proximal stripping are reproximation, slenderization, disking, interproximal reduction, and proximal slicing. Proximal stripping. Proximal surfaces are sliced to reduce the mesodistal width of the teeth so that there will be a space gained. Conservative method, mild to moderate crowding, and in case of space requirement is 0 to 2.5 mm. It is given by Ballard in 1944. It is routinely carried out in the lower anterior region. Diagnostic aids of proximal stripping are arch perimeter analysis or caries analysis, Bolton analysis, and also the intraoral periapical radiograph. Indications of proximal stripping. When there is 0 to 2.5 mm of space requirement, Bolton's excess or discrepancy, aid in retention, maintain the profile, maintain class 1 canine and molar relation. Contraindications of proximal stripping are in young patients where there is a large pulp chamber, high caries index, poor oral hygiene, and enamel hypoplasia. Advantages of proximal stripping are as follows. These are borderline cases can be treated with non-extraction treatment plan, which is a favorable overjet and overbite can be established, and it also leads to more stable results as the contact area are broadened. These are the disadvantages of proximal stripping. Roughened proximal surface which may lead to plaque retention, formation of ledges and grooves, excess tooth material reduction, increased caries susceptibility, sensitivity, alteration of tooth morphology, loss of contact which may lead to food impaction are the other disadvantages seen in case of proximal stripping. Then on seeing the amount of tooth reduction in case of proximal stripping, which is not more than 50% of enamel thickness. In the anterior region, 0.5 mm into 5 contacts, that is equal to 2.5 mm can be reduced, which is depicted in the picture right side. And in the posterior region, 0.8 mm into 8 contacts, that is 6.4 mm in the total. Following the procedure, these are the burrs or strips used in proximal stripping: metallic abrasive strips, safe-sided carborundum discs, handpiece with strips in reciprocal action, long thin tapered Fisher burr. In this picture, in the first picture here, we can see the median dark space caused by alveolar bone crest loss, followed by interproximal stripping performed with diamond steel disc at low rotation. Polishing of the stripped surfaces with flexible strips of sandpaper and white. Space created between incisors, which can be clearly seen in D picture. In the E and F, we can see the teeth coming closer with elastomeric chains, showing improvement in papillary aesthetics and closure of the median dark space. Proximal surfaces must be shaped as naturally as possible. Polishing and topical fluid application is recommended. When it is done properly, there will be no effects on interproximal tissue and bone. This picture shows the arch expansion using proximal stripping process. Next coming the method of gaining space using extraction. The first process discussed here is molar distalization. Indications for molar distalization are moderate to maxillary skeletal and or dento-alveolar protrusion, moderate arch length deficiencies, class 2 molar relation, extraction of maxillary teeth is not indicated. Contraindications for molar distalization: severe protrusive profiles, high mandibular plane angle, vertical GP, and anterior open bite, severe crowding which is more than 6 mm. The criteria to be followed during case selection for molar distalization are good soft tissue profile, dental class 2 cases, borderline cases, mild to moderate space discrepancy, third molars or second molars not yet erupted, end-on molar relation or class 2 molar relation, late mixed dentition which is ideal, early permanent dentition, growth still left in maxillary tuberosity area, 16 to 17 years in males and 14 to 15 years in females. Molars placed normally, that is buccopalatally. Classification of molar distalization. Based on location of appliance, it is extraoral or intraoral. Based on position of appliance in the mouth, it is classified into buccal or palatal. Based on type of movement, molar distalization is classified into bodily movement and tipping movement. Based on complaints needed from patient, it is divided into maximum complaints, then minimum or no complaints. Based on type of appliance, it is removable or fixed. Based on arches involved, it is classified into intra-arch or inter-arch. The extraoral appliance used in case of molar distalization are headgears, and the intraoral appliance used in case of molar distalization are pendulum appliance, coil springs made of nitide and stainless steel, distal jet, K-loop, Jones jig, magnets, modified Nance lingual appliance, TPA, micro screw implants. Distalization using headgears. It is very efficient. Reciprocal forces are not transmitted to other teeth. Molar movements depends on direction of force in the relation to the C-rest of the molar and magnitude of force applied. The disadvantage of distalization using headgear is patient complaints. Next comes the K-loop molar distalizer. Nance button connected to first premolars for anchorage. K-loop compressed and inserted between molar and first premolar. Nance button to prevent mesial movement of the premolars. Molars is distalized. Distalization of molars with repelling magnets. Nance button attached to first premolar. Repelling magnets between molar and first premolar. Nance button prevents mesial movement of premolars, resulting in molar distalization. Molar distalization with superelastic nitide wire. Pendulum appliance. Nance button to first premolar for anchorage. 0.032 TMI springs are used, embedded in acrylic, inserted into the molar lingual sheath. Broad swinging arc. Pendulum of force from midline of palate to upper molars produce molar distalization. Modifications of pendulum. The first picture is Pendex appliance and the second picture is T-Rex appliance. Next comes the distal jet appliance. Acrylic button for anchorage is attached to the first premolar. A tube and clamp from the acrylic is inserted into the lingual sheath on molar band. A compressed coil anchored to the clamp is the active unit. Jones jig. Nitide coil spring on a heavy round wire. Nance button attached to second premolar. Uprating of molars. Extraction of second premolar or early loss of E cause mesial tilting of first permanent molar into that place. Tipped molars occupies greater space, resulting in crowding of the arch. Proclination of anterior teeth. Proclination of retroclined anterior teeth will result in space gaining. Proclination can be done only when facial profile is not affected. Next procedure to gain space is derotation of posterior teeth. Here is the clinical picture to show the outcome of the result. Thank you. Hope this presentation is useful to all of you. Thank you.